Thank you, Ray. And I'm happy present today from here. And thank you very much for giving us for this presentation. First, I want to introduce you a little bit Mongolia. In Mongolia, all population in Mongolia very small, 2.8, and mean age of Mongolian population is 26.2, and very young population. And always in Mongolian live in city, in capital city, Ulaanbaatar. About 50% of population live in Ulaanbaatar. And Mongolia have high mortality rate because in this time, in 2010, average of mortality rate is 44, especially in rural area. Last time increased mortality rate in rural area, in whole country average decreased. You can see from this slide about Mongolian rural area, and in Mongolian rural area have a bad road development, and in these rural areas people live far each other. For example, in Gobi Desert, 1 square kilometer live just one or some places half people in 1 square kilometer. And I can to show you first the 5 leading death causes. And first one is cardiovascular disease. And second place is injury, and third place some cancers, especially liver cancer is very high in Mongolia. You can see from this slide how about leading causes of this. And last time increase this from injury and neoplasms. Cardiovascular deaths little bit decrease. In Mongolia, about 40% of population live in rural area, and distance between IMAX is named district, and in Mongolia have 21 provinces, and between provinces and first level hospitals located far. Some places 380 kilometers far live from the hospitals, and access limited by severe winter condition, because in Mongolia have continental climate, in winter time very cold and much snow. And from all of these causes, we had some wrong surgery and wrong place, wrong time. From all of these causes, we had high complication, after operations complication. And in Mongolia have 3 levels of health care. Primary health care named BAG, SUM hospitals. These hospitals same in family doctors, but in primary health care located far from each other, and some patients, if they had some disease, then they need to go to 300, 400 kilometers. And road is bad, and in this time, our patients lose much time. Second level is province hospitals, and we have 5 diagnostic centers and 21 private province hospitals. And all of these hospitals also located far, because Mongolian territorium is big, and small population. You can to see from this slide how about was in the beginning of 2000. In some hospitals, they haven't any possibility to do operation without light, without good supplies, techniques, and who had some trauma, they hadn't any good instruments. And this is in first level hospitals, doctors had just a few instruments, but they cannot use always all of these instruments, no sterilization and no electricity, and in this condition was difficult for Mongolia. And also you can to see electricity, operating theater and operating room, operating table and sterilization of instruments. All of these photos from 2000, in the beginning of 2000. And training didn't not much resources available in some hospitals. Some places has had much operating instruments, but they cannot use all of these instruments and just keep all of these instruments. For example, these instruments give to some first-level doctors in time human resources projects. Now in this time, we hadn't any coordination between the NGOs. And 2004, in Central Clinical Hospital operating room, you can see the very old coagulation and anesthesia machine. This was gift from Swanson's Family Foundation. And from 2004, we did assessment and we began our project. In this project participated World Health Organization and Minister of Health and Swiss surgical team, Swanson's Family Foundation. And all of these NGOs and project coordinated by Academic Health Sciences, University of Mongolia. Goal our objectives of essential emergency surgical care project was, first one is advocacy. In that time, our stakeholders and policymakers don't understand us because we need to advocate them, and just all of surgeons understand each other very well. In that time, we began our project and collaboration between foreign friends. And our capacity building was training and equipment and infrastructure, and collaboration with stakeholders in surgical care. We've implemented program by 4 phases, and in 2004, we began just orientation and advocacy. In 2005, we trained our trainers, and we chose, it was 6 provinces doctors, and we trained in 2005. And after that, until today, we trained all 14 IMAX doctors, provinces doctors, and all of first level hospital doctors and second level hospital doctors and nurses we trained together with our friends. You can to see from this slide first 6 IMAX pilot. In that time we selected IMAX where had high mortality and morbidity after operation. And we trained in this time 178 first level doctors, and also we trained whole 14 provinces doctors and second level hospitals doctors and nurses. Our IMISC toolkits was teaching and reference guidelines, training workshops, best practice protocols, disaster management guidelines, equipment lists, and policy managements. First, we translated WHO textbook and practice protocols published, distributed, training, curriculum, and guidelines worked out, and assessment list printed. We organized training by 4 main topics. First one was essential surgery. Second one is essential emergency care. Third one is obstetrics emergencies. And fourth, basic trauma care. We give them lectures and hands-on training and bedside trainings. Also distributed some supplies and instruments. And we assist first-level hospitals. And 2004, one condition was you can see from this slide. And we hadn't any disaster preparedness, and some supplies and equipments we in first-level hospitals cannot use. They just keep all of these instruments, and emergency care preparedness was in low level. In this time, in these 10 years, we trained 187 SUM doctors from 14 IMACs and 657 surgeons and anesthetist doctors, IMAC and city hospitals, and 29 midwives and felchers, 50 nurses from rural provinces. And we did in this time pre and post test, and you can see results of post-test results. We distributed emergency care kits to first-level hospitals, and total 324 first-level hospitals now they have emergency kit, and especially we distributed oxygen container. This was important for us because in emergency situation in first-level hospitals hadn't any possibility to use oxygen. And post-training, for post 2 years after training, we evaluated 16 SUM hospitals, first-level hospitals, and you can see results of our training from these slides. Also, after training, increase surgical procedures in rural area. In the beginning of 2000, some patients had small abscess patients went to the second-level hospital far from about 300, 400 kilometers. Now our first-level doctors can do some incision, wound depression, and some small incisions, suturing. You can see from this slide how about complication rates decrease in trained IMAC. From 2004 until today, in trained IMAC decreased after operations complication rate. But without training IMAC, still we have high complication. And also you will see from here how about mortality rate in trained IMACs. And from 2004 until today, decrease mortality rate and after operations complication every year. Now you can see how about operating rooms in Central National Hospital. Just a few days ago, we performed 4th and 5th living donor liver transplantation. this photo from in time, this liver transplantation operation. And for implement this project, our international participants, World Health Organization, Swiss Surgical Team, Swanson's Family Foundation, Health Front Australia, Siberian Academy Science Russia, and Asan Foundation. All of these partners and our friends helped us much, and we had close contact. For example, the Swiss Surgical Team, since 1990 until today, they train our surgeons and anesthesists and nurses. And also they give us many supplies. And Swanson's Family Foundation doctors came to Mongolia in 2004. Until today we work with them, and especially they helped us establish endoscopic surgery in rural area. From 2006 until today, they trained more than 70 surgeons and 90 scrub nurses for endoscopic surgery. And in rural area, today our Mongolian surgeons do laparoscopic cholecystectomy. And you can see from this slide, this is from 2005. After training, we with Swanson's Family Foundation surgeons. And Health from Brunn, Austria NGOs, and Siberian Academy Sciences, and Asan Foundation. All of our friends helped us much, and today we have some results, and in Mongolia developed surgical science in last 10 years developed well. For this development helped our foreign partners. After this program, systematized monitoring and evaluation of first-level hospitals and standards guidelines on basic surgical and emergency care developed, health system strengthening approach adopted, and enhanced collaboration with NGOs. This was our one of key point, because before this project, all of NGOs worked everywhere. They hadn't any collaboration. Today, all of surgical NGOs collaborated, and we have some results. And last time, also with decreased country budget and WHO budget. Now, today I introduced you about success of Mongolian surgery. Thank you very much.